Obstructive sleep apnea is much more than a nighttime disturbance. It is a modifiable risk factor for stroke, dementia, and cardiovascular disease because intermittent hypoxia and repeated microarousals trigger oxidative stress, inflammation, blood pressure fluctuations, and small injuries to cerebral vessels that over time can impair memory, attention, and processing speed. In Italy, the condition is widespread but often unrecognized. Millions of adults have an apnea-hypopnea index above 5 events per hour, yet only a minority receive a formal diagnosis, which means many live with daytime sleepiness, morning headaches, poor concentration, and irritability without linking them to fragmented sleep. The risk profile includes obesity and overweight, a short, thick neck, older age, male sex up to menopause and then leveling with women, family history, evening alcohol abuse, smoking, use of benzodiazepines or other sedatives, as well as anatomical obstructions such as deviated septum, turbinate hypertrophy, enlarged tonsils, macroglossia, or a redundant soft palate. Positional forms are not uncommon, worsening when supine, and cases may be tied to chronic nasal congestion or reflux. Warning signs not to ignore are loud habitual snoring reported by a partner, breathing pauses observed during sleep, awakenings with a choking sensation, dry mouth, frequent nighttime urination, reduced libido, low morning energy, and nodding off while driving or in meetings. In people with hypertension, a red flag is blood pressure that remains difficult to control despite multiple medications, while in patients with atrial fibrillation, recurrence after cardioversion is more likely if apnea is untreated. The diagnostic path starts with targeted history taking and an otolaryngologic exam with flexible laryngoscopy to assess obstruction sites, proceeds with screening questionnaires such as Epworth, and relies on polysomnography, lab-based or home, that records airflow, thoracoabdominal effort, oxygen saturation, heart rate, and position. The apnea-hypopnea index defines severity: mild between 5 and 15 events per hour, moderate between 15 and 30, severe above 30, with additional weight given to the depth and duration of desaturations. Treatment is gradual and personalized. Losing even 5 to 10% of body weight significantly reduces event index, as do avoiding evening alcohol and sedatives, regularizing sleep schedules, and hygiene clearing nasal obstruction with medical therapy when needed, and preferring lateral decubitus in positional cases. In smokers, quitting improves airway inflammation and nighttime patency. The cornerstone therapy for many is CPAP, a mask connected to a small device that keeps airways open with positive pressure. It reduces apneas, and snoring improves alertness and daytime performance, and lowers cardiovascular risk. Adherence rises with proper mask-fitting humidification to prevent dryness, education on use, and remote data monitoring to correct leaks and discomfort. As an alternative or adjunct, custom mandibular advancement devices made by a dentist experienced in sleep medicine are useful, especially in mild to moderate and positional apnea, while in selected CPAP-intolerant cases, hypoglossal nerve stimulation can be considered coordinating tongue advancement during inspiration to maintain a patent pharyngeal lumen. Surgery remains an option for roughly a third of patients who cannot tolerate CPAP or oral devices. Procedures range from functional nasal surgery, such as septoplasty and turbinate reduction, to soft palate and uvular work, pharyngeal remodeling techniques, and skeletal maxillomandibular advancement that expands upstream airway space. The choice depends on the collapse site documented with drug-induced sleep endoscopy. Follow-up is essential. Periodic checks review symptoms, adherence, weight, blood pressure, saturations, and quality of life. Integration with pulmonologists, cardiologists, neurologists, nutritionists, and dental sleep specialists ensures a comprehensive approach and keeps comorbidities in check, such as type 2 diabetes, dyslipidemia, metabolic syndrome, depression, and anxiety disorders, often fueled by poor sleep and chronic fatigue. Socially, treating apnea means greater road and workplace safety, fewer absences, and higher productivity. For professional drivers, there are fitness-to-drive protocols requiring proper diagnosis and therapy to protect both patient and community. The final message is simple and concrete. If you snore loudly, if someone notices breathing pauses, if you wake up tired or doze off easily during the day, don't dismiss it as a harmless quirk. Talk to your doctor, start an evaluation, and address the problem. Intervening on sleep apnea protects brain and heart, restores energy to your days, and reduces those silent risks that, accumulating at night, can present the bill years later.